In an uneventful cataract surgery, where preoperatively it was a right eye cataract surgery, 51 years male, no ocular and systemic comorbidity, uncorrected visual acuity 636, best corrected visual acuity 69, crystal clear cornea, very cooperative patient, fully dilated pupil, nuclear sclerosis grade 2 to 3. What we see in the first post-operative day is patient is comfortable with no pain, but on examination the visual acuity is 360, corneal diffuse edema from limbus to limbus, AC cells 3 plus, fibrin over the lens, hypopyon 1 millimeter, PCIOL stable and in situ, and fundus glow is plus. So we do not want this type of situation on the first post-operative day, and this is TASS. Toxic anterior segment syndrome is an acute sterile post-operative inflammatory reaction of the anterior segment tissues in response to non-infectious toxic substances. The term was coined by Monson et al. In 1992. Other terms for TASS are sterile post-operative endophthalmitis, toxic endothelial cell destruction syndrome. The clinical features of TASS are acute inflammatory process within 12 to 24 hours after intraocular surgery, inflammation mostly limited to the anterior segment, diffuse limbus to limbus corneal edema, fibrin formation, anterior chamber inflammation, and hypopyon. Gram stain and culture and PCR all negative for any microbial infestation. Clinical improvement is with steroid therapy. So we should always differentiate TASS from endophthalmitis, where in endophthalmitis it is usually after 3 days. There is severe pain in endophthalmitis, there is severe reduction in the visual acuity, there is much of vitritis in endophthalmitis. With steroid, the endophthalmitis worsens, but the TASS improves. The clinical course of TASS improves rapidly with the use of steroid. It depends on the type of toxic substance, duration of exposure, and timely initiation of the treatment. Severe cases, if not treated promptly, will lead to UZ syndrome, where the iris is damaged and won't dilate and constrict. Permanent damage to the trabecular meshwork cause ocular hypertension or secondary glaucoma, seborrheic bullous keratopathy, or epithelial downgrowth. TASS can occur after different procedures, not only cataract surgery. It has been reported to have occurred after vitrectomy with ERM peeling. There is association of TASS with IOP, TASS after intraocular posterior contact lens implant, reduced corneal density after TASS caused by intraocular ointment migration, TASS after pterygium surgery, barium contaminated IOL causing TASS, and TASS after aluminum contaminated and silicon contaminated IOL implantation. The major outbreaks worldwide have been reported from the most important was in 2013, where 251 cases were reported, where intraocular lens was contaminated with aluminum. In 2015, 147 cases where heavy metal was contaminating the intraocular lens, and 112 cases in 2005 where the balanced salt solution had endotoxin. The renewed interest of TASS at the moment is because of the reporting of 41 TASS cases by the AIOS members, specifically to the IOL from the CURE group, not proven, but they have went on to do the endotoxin level, which was less than 0.2 international unit per ml. So in the etiologenesis and pathogenesis, expected mild inflammation even after uneventful cataract surgery is expected, which is dependent on the duration of procedure and the amount of the intraocular tissue manipulation. TASS occurs due to the toxic substances entering into the AC during or immediately after surgery, breakdown of blood ocular barrier, and damage to the corneal endothelium. The most important agents indicated are the bacterial endotoxin, irrigating solutions which are not pH compatible, osmolarity, or ions, denatured OBDs, detergents in the sterilization process, and preservatives or additives to the ocular medication. Apart from the contamination, there are certain individual risk factors as well. TASS is more seen in patients who has diabetes, hypertension, hyperlipidemia, chronic ischemic heart disease, and chronic renal failure. One of the association has been plateletocrit value, whose plateletocrit value should be between 0.22 to 0.24. If more is seen, then TASS is expected. So prevention of the TASS is the key. Optimum ophthalmic instrument cleaning and sterilization process is a must. Written SOP, protocol for instrument cleaning and sterilization, regular update of the sterilization guidelines. We should follow the manufacturer directions for equipment cleaning and sterilization, devices, infusions, medications certified for intraocular use, where we should always check pH, osmolarity, ions, and it must be compatible. And endotoxin level should be less than 0.2. So
while sterilization and cleaning, there should be adequate flushing of the hollow devices. We should not allow it to dry. We should always keep it moist, and we should
clean it with distilled water, air, distilled water, air, distilled water till dry. We should be very careful while using intraocular and also even topical medications, and see whether there are preservatives, especially BAK or not. I will wash before insertion, use of non-enzymatic detergents, and if MMC or 5-fluorouracil are used, a separate tray is to be kept and processed separately. And coming in a developing countries like ours, where we are using a single-use device multiple times doing ETO, from the point of view of global warming also, reuse is necessary, but and also cost effective also. So in European country, one phaco cataract surgery will cause an carbon emission of 180 to 80 kg of carbon emission, which is equivalent to driving a 688 kilometer petrol car. So if we do the principle of reuse, reduce, and recycle, then we can definitely be cost effective as well as helping the environment as well. The option for a hospital are to stop reprocessing single-use devices by themselves and outsource a third-party reprocessor who can do the reprocessing for the devices. But in our hospital, we are doing the ETO till the instrument equipments are working, like cannulas and all this. So this is the algorithm for prevention and investigation of the TASS, which was published in BMC Ophthalmology. They have elaborately detailed what to do and what to look for. And there are TASS outbreak, and there has been recall due to the intrinsic endotoxin contamination. In 2005, the Indosol Cytosol laboratory recalled all their products of the balanced salt solution. And in October 2008, of OBDs were recalled, which was produced by Hilon D. In April 2013, intraocular lens ICER Toric 351 and Toric 311 from Hoya Opticals were recalled. In 2014, Heidelberg
OBDs were recalled. In January 2016, Rayner intraocular lens Sulcoflex Tori were recalled. Most of them were because of the endotoxin level, whereas in this January 2016 it was
because of the increased aluminum level, suspicion of aluminum contamination. So take home messages: there should be a written SOP, protocol for instrument cleaning and sterilization. We should not allow any cannulated devices to dry till the cleaning station. We should keep it moist. Rinse, flush, air flush, completely dry it before storing. I will wash before inserting into the eye. Follow manufacturers' instructions from the manufacturers. We should proactively ask for the endotoxin level from the manufacturer for any substances which are entering into the eye, from irrigating solution to OBDs to IOL periodically. Judicious reuse of single-use devices. As with all the cases of post-operative inflammation, endophthalmitis must be ruled out. So we want We don't want this middle path of the TASS. We want a clear cornea with good vision in the post-operative period. Thank you. And we'd like to invite you all to Kathmandu. There is going to be a annual conference of Nepal Ophthalmic Society from 22nd to 23rd November 2022. We'd like to invite you all to that. Thank you very much.
Thank you, Purushottam Joshi, for your nice presentation.